Hi, good morning, ladies and gentlemen. Welcome to the second sections for today, the prevention sections. I'm Silpon Ketjumpon. I'm a clinical trial physician at HIV-NAT Thai Record Aid Research Center. I'm a moderator for these sections. Our first speaker for this section is Mr. Eamonn Murphy. He's a UNAIDS Regional Director for Asia Pacific region and Eastern Europe and Central Asia regions. Mr. Murphy leads UNAIDS effort in promoting and expanded and integrated the United Nations system response for HIV for Asia Pacific, Eastern Europe, and Central Asia regions. He was the Deputy Executive Director Program AI, supporting the transition and the alignment of UNAIDS Secretariat to support the implementation of the new global AIDS strategy in 2022. Today, his topic is Universal HIV Prevention. Please join me. Welcome, Mr. Murphy.
Sawasdee Krub. Good morning, colleagues. It's great to be here with you at the Bangkok Symposium. Thank you very much to HIV-NAT and colleagues for asking me to come along and talk about prevention here in Asia and the Pacific. Before I get started, it'd be helpful for me to just get a sense in the room. If people could raise their hand if you're a clinician. Leave your hand up or raise your hand if you're someone who works 50% on prevention. Raise your hand if you're from Thailand. Raise your hand if you're not from Thailand. I won't ask you which countries. It's great to see the diversity, and it's an important part that we see both the clinical and the prevention, the treatment and the prevention working together. Not just for HIV, but we see this across many of the communicable disease programs. We've got to be careful in our own health sector of not siloing the programs and seeing them as disconnected. And today I'll touch on some aspects of where we're seeing some of the challenges with this. Now, hopefully I can get this. Yeah, okay. So firstly, let me just remind us of the data. For Asia and the Pacific, our epidemic is stalling and in some places increasing. And this is a serious concern to us, where we were, as you can see in the graph, in the red at the bottom of this slide, we were doing extremely well on a decline. We have now plateaued and starting what's referred to as an uptick, a slight increase in the regional level because of certain countries' epidemics, and I'll touch on that. You can see the global level above with a 38% decline over the same period. But for us, we're not nudging down the new infections, and that's a serious issue for us, and especially as we're seeing a shift in the nature of who is becoming infected and where the infections are occurring. And it's going to make our job collectively much harder to achieve the elimination of HIV by 2030 as a public health threat, right? And so that there's a serious issue here, and this is why prevention is so critical. So I really appreciate HIV-NAT turning in the symposium to a discussion on prevention as part of this. Let's have and I'm only talking Asia Pacific. I do look after Eastern Europe, Central Asia, but I'm not assuming we've got people in the room. So if we look at here, each time we put these slides up, we see changes in countries. One, we're not seeing the green going down far enough and fast enough, but we're also seeing shifts in epidemics in countries that we thought were stable and going the right way. Look at Fiji, a 260% increase, only recently identified. Now, there are a mix of variables, and it's not fully understood yet why. A country that had a very low level epidemic, where resources were being shifted because it was not an epidemic of growth, is suddenly rising. And it's a mix of issues that are affecting other epidemics, but does it have the strength of the health system to respond to this crisis? And being Fiji, it's a hub for the whole of the Pacific. 30 years ago, 40 years ago, we would have been very concerned about the epidemics in the Pacific. And I remember in 2001 representing Australia in New York when we negotiated the first UNGAS, And the big fear was what was going to spread across everywhere. It didn't happen, but now we have a serious potential. We're seeing it in other countries. We're still seeing a rise, you can see in the Philippines. And as Ambassador Birks, the global ambassador for PEPFAR at the time, famously said, we have 2 epidemics going on in this country. And I think we have a number of countries that have separated, connected but separated epidemics amongst the young and the old epidemics where you may be treating many of the people. But we have whole new epidemics bubbling along that we're not connecting to effectively. And you can see the death rates. Why do countries like Indonesia have such high death rates today? Right? We really have a concern. I'm talking about prevention, but there is a connection. If we're not getting the right programs out in treating people, and we're getting people into treatment services so late with advanced illness, what's that mean for our prevention programs, right? These are serious interconnected issues, and we have the same common obstacles that we're looking at. And you can see the countries across here. We have serious epidemics in places like Pakistan, which are just not being tackled at the root cause, and people are turning a blind eye to what's happening in many parts. Papua New Guinea, systemic failures of the system in supply of commodities to keep the response going. I'm just touching on a few examples, we could go through many others, of the variations that we need to make sure we don't become too generalized. And as a regional person, I've got to be careful that we're not presenting as though it's the same everywhere. And I'll touch on that. In this slide, this is at the national level based on available data, right? So each of you in your countries, you can review these slides at leisure. These are showing some of the variations and the change in epidemics over time, right? And in Thailand, in the bottom row, you can see the shift between the populations at risk and becoming infected. That means we need to make sure we're seeing the programs being timely and responsive to where the epidemic's going. And this is national data. So it has to be broken down by Bangkok versus Bangkok versus Chiang Mai, very different situations, even though they're 2 big cities, right? And then we get outside of those and we've got a very different situation, right? And Thailand's one of our most robust and effective national programs, right? So I use that as an example. The Philippines stands out there for you, right? The percentage of 94% of infections are amongst the young MSM and transgender in that country now, right? And that means a serious different way to respond. And are we equipped in our responses to prevention or even to treatment to reach the people who are becoming infected or at high risk of infection today? Because a lot of our programs are still tailored towards the old epidemics and the old responses. So we really need to see a shift in this. But I won't go through all of these in detail. You can see the variations that are occurring across the region. But particularly, of course, we have to go to the subnational level to be able to look at what we want to do. All right. So some of this we know, but this is what we're not tackling effectively. We know that in Asia Pacific, we have a highly concentrated epidemic. We have to make sure the programs are targeted to the key populations. That becomes challenging when the societal barriers, the legal, the institutional challenges that people have to overcome. We're still seeing people coming with far too late illness, which they already knew they had in large part, right? Because of the stigma, the discrimination, the impact on them and their families, right? So this is the same for prevention. If you have to go to a fixed site, often government service, people are choosing not to. The young today, of course, also have a different understanding. We're not seeing the fear that we had in the early epidemics in society around HIV. There's still an ignorance of HIV, and that comes out as a very negative. And we saw that in Fiji. The horrible stories of how people were hiding members of their family who have HIV until they died, because they won't bring them into services now, because of the stigma in society, because people don't understand HIV still, right? And part of that is if it's a small epidemic, it's not getting the public visibility. So we've got issues here of criminalization. That's the main thing. We're seeing that rising. New laws in Indonesia in this region. The politicization, the misuse of people's sexual behavior or identity in politics is also rising and pushing people underground. Why would you go to a health service or a government service and be identified by a behavior that's not acceptable either legally or socially. So these are serious challenges that we need to continue to address. And each country is looking at this, and we have data by country on these barriers. The social justice, the rights issues are fundamental. The Global Fund, PEPFAR, every program talks about this. But are we at country level investing sufficiently to address these barriers? And this is a challenge. I was asked to touch on this, not just on what we know in the way of prevention today. So when you look at this, men who have sex with men in Myanmar and Yangon, 38% avoid going to their health services. And we have a rising epidemic amongst MSM in that country. Here in Thailand, on the top right, young PLHIV, and these are where the epidemic's occurring and growing in Thailand, experiencing discrimination, yet we have really effective stigma and discrimination programs in the healthcare settings here in Thailand, and countries from the region come to learn from it. But we're still seeing it. So these are issues that need to be addressed. And there are other examples, women who use drugs in Malaysia. Why are they not accessing other forms of healthcare that are important to their lives? Female sex workers. Sometimes other programs get in the way. And so in a country like Cambodia, we've seen a crackdown on trafficking. And then that causes problems for the effective programs that were in place for sex workers in that country. Young, I talked about the young. This is a critical issue because this is where we're seeing the data shifts. And the bottom left slide, you can see the numbers, the proportion of young people among new infections, and how they're higher than our regional average and the global. So across the board, strong, robust epidemics like responses like we see in Vietnam, in Cambodia and Thailand, we're still seeing rising new infections amongst the young. Right? So this means we need to rethink of some of the programs, and we have to start readdressing some of the age-old issues, institutional stigma that we have to some of the issues. When we talk about PrEP, I too often hear people saying, oh, but what about the condom? Condom's important, of course. STIs are issues, but condom as an anti-alternative to PrEP. So people are just not getting what's the underlying issue here. And that's about people's realities and sexual behaviors and a discomfort with this, right? And so this is something that we continually will need to challenge and respond to. Otherwise, we're not going to be effective. Here you can see in the pie graph, we're even higher in proportionality when we look at the young and its key pop-driven epidemics, right? Now, if they're being driven underground, they're spreading because many of them will have sexual partners who are outside the key populations as well. Or in the case of drug use, and I know Stefan's going to talk on chemsex, so I won't go too far into that in my presentation. We're going to see that that's playing out new dynamics in places like Fiji, where it is part of the dynamic, but it's chemsex amongst the heterosexual party crowd. Right? And so that's a different dynamic. And I see that particularly in Central Asia, where methamphetamines and pill-based party drugs are on the rise amongst the heterosexual party crowds, and how it's being used for sexualized drug use, as we'd refer to it. You can see the rise in different countries and the issues here. Right? So these are going to be a real concern for us that we need to seriously shift our responses. I'm only touching on certain areas here, we need to do more review in individual countries of what's happening with different groups. Here we can see in the large circles, the regional median. MSM, as I showed earlier, is the rising population as a proportion of new infections across the region in most countries. Yet where do we see coverage of services for prevention? And I would put to you, also access to treatment is something that they're not accessing early enough, right? For a number of reasons, but the stigma and discrimination and the type of programs. Philippines introduced the twilight or the evening clinic, so people who work all day could access health services. So they didn't have to take time off work between 8 and 4 when they're busy in their offices, so they could access. In India, there are great examples where it's online counseling, self-testing, and it's done to the person at home with the support of somebody online. We've got to change the nature of our programs, not assume people are going to come to us in this day and age, and particularly with the understandings of HIV and treatment availability, yet it's not being seen in the uptake. So there's still a big issue. Injection drug use, still an issue in a number of our countries. Myanmar has now overtaken Afghanistan again as the major producer, both of heroin supply and also methamphetamine. So we're seeing rising drug use across the region. And there have been some big drug busts here in Thailand that shows the pathways of the drugs programs, and we really need to reinvigorate the whole response around injection drug use. Right? So I won't go through all the details here, and the different countries are in different stages, and it really needs that local analysis. Chemsex, turning to prevention examples, I'm not going to go into the details here. Stefan can critique this differently, but this is a serious issue. And as I heard recently in Malaysia, one of the challenges for the health system there that has done some really, really effective work in dealing with heroin-based epidemic amongst drug use, and we bring countries from all over the region to learn from their response. The challenge for them to advise the senior officials in the health system is what to do about the methamphetamine epidemic, because there's no buprenorphine, no methadone, there's no treatment option that's clearly seen. So it's a challenge. I hear health officials across ASEAN struggling with what to do with this. It's a reality across the region, and it's a reality globally that this is going to be there. And people are seeing sexualized drug use, as they always have used drugs to enhance sexual pleasure. But now we have new forms of drugs that are having a serious impact and causing the related sexual transmission of HIV. So I won't go further on this one. To me, I want to focus more on the issue of PrEP. PrEP we talk about a lot. We talk in Asia Pacific as though we are scaling up PrEP. But the reality is, PrEP is only just being introduced almost in pilot or testing still in many countries because of the scale. And you can see here the gap. To reach our 2025 targets for PrEP for this region, and we're going to have to do more work on tailored targets per country, and that we're working with the World Health Organization on, so you'll hear more about that in the coming year. We're only at 4%. We've got a long way to go. We have some countries that are scaling up, others who are just introducing and still watching. And you have to question why, when we know the efficacy. In Australia, we've seen in Sydney and New South Wales a 31% decline in new infections with the introduction of PrEP, with good testing, good treatment programs as well, but a 31% decline in 1 year alone. So they will be able to work towards seeking to achieve the elimination of HIV as a public health threat because of the introduction of PrEP. So we know even in our own region, it is a significant boost to the response and it has the efficacy. But we're not seeing the political commitment. We're not seeing the engagement that we need to see by decision makers, and that includes all of us understanding and advocating within our own systems for the scale up, not just the introduction of PrEP. A lot of the pilot programs then just stop when the funding from outside partners dries up. And we are not seeing domestic investment in prevention services of all sorts. So PrEP uptake is far too slow for us. We need to really invest in this. And it's the regulatory, there's a whole range of issues that need to be looked at. The lack of policy, the policy to practice where it's been introduced but not moved at the provincial level, not easily available through community services. We have to learn from COVID, where we made changes in our service delivery for a whole range of communicable and non-communicable health service provision, and keep that going and seeing it in the case of PrEP. It can be through pharmacies, it can be home deliveries, a whole range of options, but we're not seeing the investment. And even here in Thailand, we're not seeing the financial resources flow through to the community sector, who has the outreach and will have the impact with PrEP expansion. So we need to see this change for the scale up across the board. So I won't go through the details of this. We've also got to make sure that we're not limiting ourselves with PrEP. Too often we talk about PrEP as though it's for MSM only, but we're seeing really effective programs in Africa for the general community. But we're not seeing that discussion here. And we have now a new regional PrEP advisor for both WHO and UNAIDS who's going to be working on that issue, because Sushena is coming out of India where she was doing programs for sex workers. She's doing programs for women and PrEP. Transgender, we have to get the dialogue moving. It is a whole of response opportunity for us, and we are just not investing and creating the demand. And to do that, we still need to look at some of these structural barriers. The other areas, status of needle and syringe programs. We have really seen a decline in investment for harm reduction and opioid-based epidemics. Yet we're seeing a rise in the availability and the price of it. So we really need to be looking at that seriously again, and the investment by domestic governments in this. The epidemic shift, as you saw, the data does tell us we have to make some hard decisions where we have limited budgets, but we've got to make sure we're not stopping the effective programs. And of course, the related benefits of hepatitis C and other programs, when we look at working with the drug-using community on the holistic nature of their needs. This is often overshadowed now by the discussions around chemsex, but we're not investing enough in what we know works. The whole area of testing and self-testing. Again, it's like PrEP. We're seeing some of the policies being introduced, but some big epidemic countries like India, where a lot of the test kits are produced, self-test kits, we're not seeing national policy and implementation of self-testing. We need to see a significant increase, because people want to know their status before they engage with the health system. They don't want to go into the health system to find out. And that's for a whole range of those societal barriers. So let's meet them where they're at. We need to do it online. Most of the young today, I have a 28-year-old, even my 9-year-old, they live on that mobile technology. That's where their worlds are, right? They have virtual games. I was hearing yesterday how they have flight simulators, and then they have the air traffic controllers, and these are all people who don't know each other. So our world is different when we think in our public health responses that we're used to. The young today live in a very different dynamic, and we need to shift, particularly with self-testing, which is such a critical tool for us as we move forward. And the price affordability is right down. Here in Thailand, they're working right now to even get it lower. That will make it much more available. We need people to know their status. They can make decisions how to prevent further transmission to other people whilst they're considering treatment access as well. But they can then move into the health system with support if we retool our programs to provide it and make these easily available, just like the COVID self-tests that were available everywhere. We need to get this out into the community and through pharmacies and other mediums, not just through our usual health system structures. So we have some serious work to do around the whole dynamics of different types of testing, but particularly for today, I'll just touch on self-testing. And I'm assuming someone out here is going to click at me or show me a sign when I'm up to time. The other area, when we talk to treatment, and with such a large number of our clinicians in the room, treatment as prevention is still critical. But we're not seeing treatment scale up fast enough either to really have that impact, right? And you can see here where we've got the treatment coverage and where we don't. And if you look at the red and orange and the lighter green, right, we're seeing some of the same countries that we saw earlier with rising epidemics. So where are the investments not occurring even in treatment in these countries? And yet there are other countries like Malaysia with its resources, with its really robust health system. Why is treatment coverage so low, right? I'm going to be spoken to by some governments later. But you can see it across the board. We have some really serious work to do just in treatment if we want to make it part of the treatment as prevention dynamic as well. But also to help us show people that there's an incentive to access the systems. Treatment has to be available, and the whole issue of the stigma and discrimination needs to be removed. Where I won't name a country that I was visiting a health clinic recently, and you didn't need to wait for the healthcare worker to tell you your result. The colour of your file that they put on the table would tell you your result. So if we're still doing that old-fashioned stigma and discrimination in our own settings today, we really haven't progressed far in some places. The other part of treatment, which is critical for us, we need to have treatment easily available and easy for people to sustain their treatment adherence so they can achieve viral suppression. I take a moment on U=U and the zero transmission. The World Health Organization at IAS in Brisbane has come out and released its findings to confirm what we all knew. Right? So we have the weight behind the argument of U=U. Right? So we know the risks are reduced so significantly to be negligible. But we're not seeing an investment in the whole issue of U=U. Are we hearing it spoken of loud enough? Are your programs talking to people about why starting treatment early and retaining them treatment adherence is going to have an impact both on their personal life, but then on their family's life, the community, and further on transmission in society? It also underscores some of those institutional and those structural barriers. If someone can see the benefit of U=U, if the community can understand, people who are enabled to access treatment don't pass on the virus, it changes the whole dynamic and understanding of HIV. So for us as public health people, we need to think about how we can use the power of that message of zero transmission to both get people into our treatment programs, but to see the benefits for society and for forward transmission. It's a serious tool that we're not seeing enough use of in our programs. And so we need to really scale up the understanding around this and change that whole societal understanding of HIV and the threat of HIV and the fear of HIV. So in summary, we need to renew and intensify our focus on the key populations in policies and programs. Right? We have very different epidemics here than we do in Africa, and sometimes I wonder when I go to countries why I'm hearing so much about transmission among the populations that are at low risk or low percentage of the overall, right? And so we've still got some serious challenges when it comes to these issues. I won't go through each of these. These will be provided. Our HIV service delivery, the community-led programming, the investments are not there in community-led and community-delivered services, yet we know they're so effective. We saw that in COVID as well, where we could bypass some of the barriers that were put in place in responding to the differentiated service delivery, not just for PrEP, but for other programs as well. PEP is part of it, strengthen the integration. We've got to make sure increasingly that HIV, as we go forward, is fully funded and fully seen as part and not a silo program, either siloed within the response to HIV between treatment and prevention and also within the health system. We've got plenty of good examples across the region that can be used, and I won't be going through those today. Right? The barriers to equitable program coverage. This is serious where in some of the countries we're only dealing with those we're most comfortable with, and that's not having the impact on the epidemic. And it's not keeping those we're most comfortable safe. And if you look back at those slides by countries, the women who are at risk for no other variable than being women in society, this is still an issue of concern. In some places, of course, people are hiding their risk behaviours, and then the transmission is occurring. So again, why we need to look at the barriers, structural barriers. The domestic resourcing. I'm not putting up slides on this topic other than what we all know. Our health systems don't get enough money, and domestically we're investing largely in the treatment programs and not in the prevention programs. And even the investments in treatment are too slow to have that protective benefit. So the global targets that our countries, just to remind us, this time round with the political declaration, the countries have identified new targets, not just the treatment targets and the 95 targets, if you're familiar with the 90s or the 95s. Initially, they were just very broad targets. Now they're by population. And so we need to see the programs much more tailored and broken down so that we are seeing what is the reach to each of the populations at risk rather than a general population analysis. We also need to be seeing on the 10s targets, and these are around the structural barriers, reducing stigma and discrimination, eliminating punitive policies and laws. We have serious work to do. The countries have signed up to it. Many of them, I think, don't really understand what they need to do to achieve these. So we're going to see some more, a lot more discussion and work on this. But this is a systemic issue, not just for HIV. But that doesn't mean we don't have to collectively seek these issues of inequalities in our societies to be addressed from a public health perspective. We have some good examples, but overall, this is what's holding us back. The 30, 60, 80 targets are around the role of the communities. Our most effective responses to HIV and other public health programs engage the communities from the outset. Planning, monitoring, evaluating, design, but also implementation. And we're seeing a cut in funding to the implementation modalities via communities, which are the most effective delivery mechanism if we're going to reach the communities, particularly today with the young, who are even less likely to come forward to the standard fixed site and traditional services. So we need to see a shift in the response. And so the global commitments our governments have made match what we know needs to be done with our responses to prevention particularly, but also to treatment. But we're not yet seeing it. So we need you to all be advocates for change within your systems and not just look at your aspect of it, but to see why the different parts of the overall response are so interconnected and needed to be moving forward at a much faster pace across the board. Thank you very much.
Thank you very much, Mr. Murphy, for your excellence.